Ladies and gentlemen, a very good afternoon to you and welcome to the Health Chat. It's a Health Chat with Roy Lilly with one big difference. If we could run the VT, please.
Hi, this is Roy Lilly. I'm really sorry not to be with you at your conference. I was very much looking forward to coming across. Unfortunately, on a long-haul flight back from Australia, I've picked up labyrinthitis, which is a virus of the inner ear. And the docs have given me some medicine, but fundamentally I can stand up, but I can't turn around, and I'm kind of marooned on the sofa. I can't drive, I'm not allowed to fly, I can't drink booze, I can't drink coffee. In fact, life isn't worth living. However, I will be following you on Periscope. You've got a great guest with a really interesting backstory and a huge challenge in some difficult times. So I'll be following you on Periscope. I'll be sending you in some questions. Have a great time, and please accept my apologies, and I hope to see you all real soon. Thank you. Bye-bye.
So our sincere apologies, Roy can't be here. We got a text from him yesterday morning pleading for sympathy. If anybody knows Roy, he'd probably have crawled, he'd probably have swam if he could have done, but clearly it was just too short notice to get him to put that effort in. If any of you have enjoyed the Health Chats before, then you'll have an idea of the format. Very kindly for us, my colleague, Professor Michael Thick, is our Chief Medical Officer and Chief Clinical Information Officer, has stepped in to do what I hope will be a much more gentler form of an interview than Roy would normally do. And of course, it's absolutely fantastic for us to have the opportunity to have a chat with Sean. And we find these sessions, the format is really quite intimate, quite informal. And although we have an audience here, we are streaming this live on Periscope. And we quite often get audiences. Last week we had about 6,000 live followers, and by the end of the week, when that goes up onto YouTube, that can usually double. It can be 10 or 12,000 people. So just to bear in mind that what's happening here is being streamed live. And if I may, I'll introduce myself. My name's Shane Tickell. I'm Chief Executive of IMS MAXIMS. IMS is a provider of electronic patient records, and we have a great interest here in what it is that you're trying to achieve over the course of the next couple of decades. And one of the things IMS does is, well, we tend not to do advertising. What we'd like to do is to help facilitate transfer of good practice and knowledge. So we've worked with Roy and his team for a couple of years now, not just in supporting and facilitating the Health Chats, but also in his work with the Fabulous Academy and the Fabulous Change Days. And if you'd like to know more about those, I would suggest you Google them. But enough from me. What I'd like to do is hand you over now to my colleague, Professor Michael, and to Sean, and enjoy the next hour and a half. Thank you.
Thank you very much, Sean, and hello, Roy. It's really nice not to see you. And those of you who've followed Health Chats will know exactly why I say that. And a real pleasure to have a chance to talk to you today and to hear how you did what you did and what you're doing. We all know that IT projects get smothered at birth in finance directors' offices most of the time. How come someone with an accountant's background has got to this position, and can you tell us how you got here?
Yeah, is that a question about my background, Michael? Initially,
yes,
yeah,
yours.
yeah, okay. Well, I'll give you a quick potted history if it's of interest. Then, so as you say, I'm an accountant by background. I joined many moons ago the civil service, liked the look of the health service, and made the switch across from the civil service to the health service, and had a career in finance up to I think the early 90s when I became Director of Finance at the Mater Hospital, similarly at the Royal Hospitals, and then back to the Mater Hospital as Chief Executive for about 4 years, which is a very special time in my career. Thereafter, I moved from that role, because at that point there was a major reorganisation of health and social care, and we resolved to create at that time what was being referred to as a Health and Social Care Authority. David Sisling came across from the UK to head up the organisation, and we spent about a year preparing for it, and then our new assembly was restored. We're back in 2007, and the then Minister, Michael McGimsey, decided it was not the design that he preferred, and we had a retake on that, and I, along with a few others, found ourselves kind of marooned by that decision. Spent a couple of years in the Department of Health, working alongside them on secondment. For my sins, worked on the finance and HR shared services program, on the establishment of the business service organisation as it now is. And I took then a role just by public advertisement. I became a Deputy Secretary in the Department of Health, looking at the resources and performance management job, and I did that up until about 2009 when I joined the Northern Health and Social Care Trust as its chief executive. I did that job for about 2.5 years and moved from there into the role that I'm in now as Director of eHealth for Health and Social Care, working for the Health and Social Care Board.
So they clearly almost deliberately show someone with no technical background at all.
And no, I don't have a technical background. I've always had an interest and a passion for what information and IT could do for health and social care, but the idea of my taking the role as Director of eHealth was to first of all create a senior board position, and secondly to make sure that what technology and information could do was linked to the challenges that the services had. I think we've had some success over that over the course of the past 5 years of helping health and social care as a whole at a time when people are becoming more aware of the potential for eHealth, for digital support for change to be effective. Had become more aware of what it could do for Northern Ireland, and we had some wonderful successes along the way that have helped lift that ambition, including, as I mentioned this morning, the electronic care record, and some of the folk in the audience had a large hand in embedding that particular change.
Well, given your shrewd management role, having observed what happened in the UK with the national procurement, what made you decide to go for a national procurement here?
Well, I suppose the phrase national procurement, when you apply it to Northern Ireland as comparing it to England and Wales, I think, has a different feel to it. And we did spend some time this morning comparing ourselves at a population of 1.8 million with the population of England and Wales, I think about 54 million or thereabouts. And it was useful to have time with Will Smart and colleagues. We reminded ourselves that at that population size, we're about kind of 2/3 the size of a sustainability transformation project, the kind of collaboratives that have been used to focus on what change was possible in the English context. And that change had been delegated to those levels as a scale and as a size of population, with all the attendant economies of scale and issues and spans of control that make change at that level more meaningful. So I would distinguish us from NPFIT, which was an attempt to come up with one solution for 54 million people, whereas ours is an attempt to come up with an integrated solution for a little less than 2 million people, which I think is entirely appropriate. So that's the key distinction. I think if we were trying to do that, having learned the lessons from NPFIT without reference to it, it would be foolish of us. The other context I think that encourages us, and we talked a little bit about this earlier, is the sheer delight that health and social care professionals have taken in that which we have achieved to date. And in particular, I'm thinking about our secondary care colleagues. In some respects, it's old hat for primary care, old hat for our primary care services that has been effectively digital now for some 10 years. And GPs from time to time would gently remind us that we're living in a different age than they are, that they had embraced that challenge some time ago. We should learn from their experience, and they're right. So the folk who have had the learning and had the joy over the course of the past 5 years of seeing digital transform how they can work is mostly in the secondary care sector, although GPs and others have benefited also, as have our community nurses and our social workers, from the advantages of the Northern Ireland electronic care records. So I'll not rehash all that we said earlier, but a very granular summary record that, for example, can see a consultant preparing his outpatient clinic at home, having access to all the information that he or she would have needed in order to be fully prepped moving into that outpatient clinic. It's become an essential tool for nurses who manage a caseload in the community setting to understand pending appointments for their patients, to understand current medications, to understand recent contacts with health and social care. So whilst it's a read record, with some exceptions, there are some elements of functionality that it has been able to deliver. It's primarily an alternative to trying to read a paper chart. And it's been a fantastic success. We have, as I say, out of 65,000 staff, we're well over 20,000 regular users. It's won, I think, about 3 national awards thus far for its capacity to integrate care. But we have come to the view, 5 years on now, it's a relatively mature implementation. There are still more things to happen. There's more benefit to be had from that relatively modest investment at about £14 million for Northern Ireland thus far. But having said that, I think we've all recognized that we're approaching a ceiling on what can be delivered with a read record, with a summary care record of that nature. And we have an appetite, partly whetted by the success of GPs, by the success of the NICR and other developments, because they're not the only things that have been happening in Northern Ireland, to do something more fundamental, to do something more ambitious. And it was that led us into a discussion about saying, and what should we do beyond the life of the current NICR, and more particularly beyond the life of the suite of systems that support our hospitals, all of which reach their sell-by date in 2021, as it happens. I think was it Brian McKeown last night when he stood up and said, weren't we clever? It's still working now, and we put it in 1984. Well, it reflects the fact that it did in 1984. Fantastic work has been done across health and social care to keep it maintained, keep it resilient, keep it relevant. But it's not a modern platform. I think the analogy that a few of us have drawn on a few occasions is that as we think about replacing it, we're effectively going to buy a smart TV of some description for the black and white portable that we've been relying on in the course of the last 15 or 20 years. So that was where the debate got us to, and I think it really is just about, well, here, look what we can do with modest investment that allows us to reduce reliance on paper and make it more possible to get the information we need at the time we need it, sitting in front of a patient. Imagine how it could be if all of our information were available as a single record, and no matter where you were treating a patient, you could see their history, you could see pending events for them, and better still, we could allow patients to share that information also.
It was quite a lively topic this morning in some of the earlier sessions, so can I just pick at the national versus local issue again? As you know, our STPs are being broken down a little bit further into what were first called accountable care organizations, but because that resonated so directly with American systems, that terminology was abandoned pretty quickly. I see your Bergoa report recommends that you have a very similar accountable care systems as a proposition for how you organize your service here. And they are very keen to foster local process. So do you see that there's going to be any conflict between your evident desire to have pretty strong national process against the Bergoa report, where they're saying you can get good practice and you can get good outcomes from local ways of doing it as well as national ones?
I think there's always a tension, but I think the tension's fully resolvable. And certainly the frustration that we have picked up as part of our debate about where should we be headed with technology is the frustration that's regularly voiced to us by staff who care for patients who have to cross boundaries. And for example, a little bit less than a quarter, I think it is, of the total population of Northern Ireland move across boundaries, most frequently to central Belfast hospitals for specialist services from the parts of Northern Ireland that don't have those specialist services, but also for normal movement associated with just moving home, with moving on in your life. We have a huge level of frustration around saying, but as I cross the boundary, I lose the information that was available to me, and I have to embrace a different process in order to continue to support that patient, and it introduces risks at those interfaces. So I think there are risks to be managed around a perception of telling people how to do things, but to be fair, as we've spoken with staff, and again, I suppose it's the word national versus our scale at 1.8 million people, our sense is that there is a strong appetite, not to say that it's an easy thing to do, but there's a strong appetite to come up with consistent ways of delivering care without them being absolutely prescriptive. And so the 80-20 rule that we talked about earlier, there'll be occasions when a care pathway will work differently because you don't have 24/7 access to an MRI scanner in your local area, and therefore your care pathway will have to reflect that. But for the most part, we can see no reason, and clinicians tell us there is no reason why at the level of Northern Ireland we would not introduce standardised care pathways and allow some discretion around when those have to be applied, so that, and I think the example was given earlier, the vast majority of straightforward care can be done more effectively to free some of that time to ensure there is tailored care where standard care doesn't work for the most complex cases. And really that's what we want to see nurses, doctors and AHPs operating at the top of their license, be able to deal with routine cases on a best practice accepted model, but varying away from those routine ways of dealing with patients where the complexity of the presentation merits it. So I don't see any conflict, to be honest, between the two. I do see the challenges that have been faced at the level of England nationally. And that's not to say that we won't have challenges, because it's not infrequent for everyone to nod in agreement that we should move to consensus on a care process, but insist it's their care process that we should move to consensus on. But there is that agreement in principle, and I think it's deliverable for us.
I've heard you say several times now that the electronic summary care record that you have is largely readable. That kind of begs the question, who does write in it, and how is it maintained?
I mentioned earlier that the patient administration system that we have dates from 1984, and the staff who manage and maintain that have done a fantastic job of keeping it up to date, relevant and resilient for us. We have a whole range of other information systems that collect and report data on radiology, on laboratory testing, on referrals, on discharge letters. Many of them are associated with the PASS system. Some of them are systems that are independent of PASS. And effectively what our clinical portal does, the NICR, also referred to as our clinical portal, is it provides a window into all of those systems. So it exposes information that's captured digitally in all of those systems. I could go on and reference systems such as our community information system. So uniquely, I think, or relatively uniquely in Northern Ireland, we're able to display community information also in that summary electronic care record. But it does mean that where there is workflow, that is either recorded directly into those systems or through administrative support into those systems, or worst case scenario with paper, and at a later point captured digitally as part of that electronic care record and exposed to patients with differing views depending on the role of the, exposed to staff, differing views depending on the role of the individual staff members.
Given that that appears to work pretty well, and you've got a very broad clinical approval of what's happening, what made you take the decision to completely scrap all that and have a national procurement for all those systems you've just described?
Well, we haven't taken a decision to completely scrap it. First of all, we're continuing to invest in the electronic care record between now and 2022. The reason that we have begun to look at what we require for the future was, as I mentioned earlier, the knowledge that our 1984 acquired patient administration systems could not last and could not meet the demands we needed to place on them beyond 2021. I think I mentioned earlier that we do not yet have electronic prescribing and medicines administration in Northern Ireland. We know the harm that is caused by prescribing error. We know why that harm is caused, just the sheer complexity of both the human interactions and the complexity of prescribing processes. And we know that one of the key areas that will deliver benefit in that regard is closed-loop electronic prescribing and medicines administration. The evidence base is there. Brian Robson approached me after our discussion to say, and we'll share the work we've done with you on HIPMA, the Scottish acronym for electronic prescribing and medicines administration. So the evidence base, I think, is there. And we'd already begun a project to say we must consider electronic prescribing for Northern Ireland, given the potential to reduce harm. However, when we talked to the market and indeed to our clinical colleagues about what was possible, the other big deficit, I should say, Michael, is care noting. So we still have nurses recording in charts, recording observations in charts, never mind prescribing administrations on cardexes, doctors using paper for handover, nurses using paper for handover. And we'd arrived at the view that there were some due minimums that we must have by 2021, and they're really to replace a system that's too old and which isn't fit for the purpose for the future, to have electronic prescribing, and to support staff to work digitally to share that information more effectively. And when we began to talk to the market in the usual kind of market sounding exercise, the crossover between those three requirements and the companies who said they could do it was so strong, along with evidence that was presented to us from visits that we had made and from conversations that we'd had in Scotland and Scandinavia with some colleagues in America who were willing to share their experience with us, was you're talking to the same market sector when you go across those 3 areas. You could well wind up with the same supplier. There are material advantages to be had in linking prescribing systems in an integrated way with the electronic patient record. And the other thing that came to our attention, the other potential, was the potential to link it more broadly beyond the acute sector and out into community health and social care. And for the longer term, to consider primary care systems also. So it really came as a result of the appetite that came within health and social care, the reminder to us on many occasions from staff that the real high-risk transitions for patients were from one setting to another, and that if we couldn't help them with a solution that moved from one setting to another, there was an element of risk that we weren't going to address. And the fact that as we began to talk about replacing this whole system, we were naturally in the environment of discussing something that at a minimum allowed staff to work digitally at a hospital level in terms of care noting and to embrace electronic prescribing. So it seemed a natural extension to us to at least consider moving beyond the walls of the hospital to embrace more of that care journey and to address more of those care transitions.
Well, you've said on several occasions that you're aiming for an EPR for both primary and secondary care. Are you getting any noises out of primary care that they're worried that the systems they like might be encroached on? Or
Well, we certainly are. And just to be clear, what we've said we're aiming for is an EPR for secondary and community care, and we want to explore the potential then for such a system to support primary care in due course. So the community systems for Northern Ireland, the systems supporting the work that district nurses do, the work that social care staff for older people do, the work that allied health professions do in supporting rehabilitation and so forth. That information is collected by a variety of systems currently in each of the 5 trusts. And just as we took stock of our commitment to electronic prescribing, so too we took stock of our commitment to upgrade some of those systems. And in light of what our research told us, said, well, we shouldn't do that. We should explore whether, first of all, there's the appetite, and the appetite from health and social care staff is clear. And secondly, whether the market can meet that appetite to have joined up care processes that work across transitions of care. In regard to primary care, there is cynicism, because again, our GP colleagues will say, well, let's see how you get on. We've been doing this for 10 years. We'd be very interested to see how you newbies to the digital agenda will fare when it comes to implementing these systems at scale. But they're enthused about it. They do want to stay connected to it. GPs are as you know, they're an integral part of the patient journey. So, for example, when we've had debates about care pathways, what sometimes gets in the way of us being able to manage an effective care pathway together is the fact that we can't say to very busy staff, whether they be community nurses working with our current Civica Paris solution in a community setting, or whether they be GPs working with EMIS or Vision or whatever it happens to be, would you ever mind also inputting the information to this other system as well? And we're back to the land of building multiple interfaces and the risk that comes with trying to transition information from one place to another. So we have talked to our GPs about the fact that we would wish to say to whichever supplier becomes our partner for the long term, and we recognize that's what this will be, a long-term partnership, that we would expect them to develop a system that's capable of meeting the requirements of primary care, and for that to be available as a choice for primary care to make. And we would hope that there'd be some enthused practices in primary care who want to work with us on that. But that's something that comes after we've met the need for hospital and community health and social care.
You talked quite a bit about clinical engagement. Could you tell us what sort of structure you have in mind for your CCIOs and how you intend to get them educated and joined into the whole process? Because it's proving to be a very critical part of what's happening, certainly in England.
Yeah. So we effectively seed funded the creation of CCIO posts in each of the health and social care trusts about 3 to 4 years ago. 3 years ago now. And we have a CCIO leader identified in each of those trusts. So those individuals are part of the health and social care organisations to which they were appointed. They were appointed by the relevant board member in each of those organisations to support them in their work. I think we have more work to do to support that CCIO community, to adopt more of a leadership role in each of those health and social care organisations. There have been some successes to date in them acting as a focus for clinical opinion and acting as a lightning rod for the debates, for example, in relation to Encompass. But at this time, they are not posts that are part of a regional command and control structure. They are posts that are part of the individual health and social care trusts, which employs them to provide a leadership role in those settings and in those organisations.
Do you, as an ex-trust chief executive, see a role for a CCIO on a trust board?
I do. And I think we have a journey to cover in Northern Ireland. I'd mentioned earlier that the CCIO posts were effectively seed funded. I am the only ICT leader in Northern Ireland who sits on a board, on the board of the Health and Social Care Board. For the most part, the information agenda is led within individual delivery organisations, trusts, by a director of planning who also carries that remit for information. And they're very enthused and very passionate about their role. But I think we have a journey to go on to get to the point where there is an information leader on the board. And it would seem sensible to me, and it would seem the right choice to make, that you would expect that person would hail from the care professional community, whether they're AHP, doctor or nurse, but they would come from a care professional background. So there's a journey to be made, and I would wish to see that for the future, absolutely.
Well, we recently went to a conference in England on digital health leadership, and there was a chief executive there who was a very strong proponent of including CCIOs in the process of acquisition of EPRs and their implementation. He was adamantly against having them on the board, much to everybody's surprise. It's well known that these technology projects are often the field on which the clinico-managerial battle is fought. Do you sense that happening here, or do you think you've got over all that now?
Well, I think somewhere in between. I don't think there's a sense of strong division between our clinicians and those who have more formal management responsibilities. I suppose when I talk about a CCIO being on the board, I don't really see that as well as someone else who has responsibility for information at board level. I would think in time we would hope and expect that we'll have sufficient interested care professionals who will become those information leaders at board level. No, there's been a very strong appetite, and again, it's back to the success that we've had with the electronic care record. Interestingly, when we talk to groups of care professionals, the appetite for what we've talked about as Encompass is very strong, linked to risk at transitions, linked to frustration with not having access to the information you need to make a decision there and then, linked to an inability to see patterns at the population level, and our public health clinicians at the population level and many others are hungry for that change. I think if there's a nervousness, it does come at the organisational level, because it is the organisations then who I think are painfully aware of the scale of the change challenge that's likely to bring their way as they struggle with many other challenges, including managing access to services as things stand. So peculiarly, it's a little bit inverted. We have a lobby from care professionals to say, this is the way to go, this is where we need to be, can we hurry on, please? And a sense of, whoa, that's a lot that you're asking of us as organisations to embrace that level of change over that period of time. And we need to support the organisations and give them the confidence that the change is indeed manageable. But there is a joined-up appetite, so there's no sense of clinicians want one thing and managers want another. I'm sure you'll find that in some quarters, but not as a rule or as a general context for the changes we're talking about.
Yes, it's certainly the sense that I get here is that there's a much better dialogue between clinicians and managers and a common understanding of where they want to go. We heard Jason Hall this morning from BT talk about the idea that those in need of healthcare are going to become effectively digital customers. and that they will bring with them the attitudes to buying that they do in the high street and elsewhere. When you look at what's happening with primary care and that digital customers are electing to go for GPs that they find online, they completely reject the old primary care model. And I haven't yet heard of a GP who subscribes to the idea that having online stuff is a good idea, or online services. Do you think that the laying down of such a big infrastructure that you're proposing will in fact stifle innovation, or how will it let it happen?
Well, I suppose there's a few angles to that, and I heard Jason make reference to whether opening up digital channels for communication in an era when demand for instant response to challenges or problems has become more prevalent would prime more demand. Certainly that's something that we need to think about. We need to think about how to handle that. But we know that we'll stay a ration service. And one of the biggest challenges for health and social care is that active rationing. And I think the attraction for us in a digital offering is where that digital offering meets the need that our customers have without necessarily requiring them to take the time of a health and social care professional or have to find themselves moving through a queue of some kind to sit in front of a health and social care professional before they get access to the information that they require. Or indeed that we put them through a series of process steps at which care professionals guard and police every element of it as our normal rationing model, when what we're doing is creating work for both them and for the health and social care professionals in so doing. So I suppose if that's the cup half empty, I'd like to think of the cup half full, which is that there is the opportunity to take material chunks of those patient care processes out of those digitally enabled journeys without risk to the patients, with increased transparency for them as to what's likely to happen next in their journey, who they're likely to see, what the decision has been reached as to the next step in their care, the capacity to move away from care consultations and share that information with relatives rather than come back with a worried and long queue of questions for the next time in which they see a health and social care professional. So I don't have an answer to the problem that Jason cited. Are we going to be overwhelmed, as we open digital channels? And I think some of the practices that we've had about how we manage that without digital channels will probably move over into the digital sphere. There'll be things for which queues are not necessary because they're simply available value that we can offer to customers, and there'll be areas where queues are necessary. But it would be my hope and expectation that in taking out much of the rework associated with non-digital processes, that we'll deal with some of that dearth of capacity which blights our service now, or at least contain the cost of meeting the full demands that are placed on us.
I hear from you that the funding decision is available in about 3 weeks or so. The Business Services Organization gave you a pretty hard time. What was that all about?
I don't know who you've been talking to, Michael. So yeah, right across the service, when we made the business case for health and social care and for a digital platform for the future, there were a whole range of questions which came up. They came up from trusts as well as from the Business Services Organisation. And I think, to be fair to folk whose lifeblood has been technology and the technology we've got now and how that technology can evolve, there's a strong concern about moving too many steps at once. So what has tended to work best in the past has been gentle evolution. And that's where the lowest risk sits. However, it is also the case that gentle evolution from where we are now is not capable of getting us some of the outcomes that we require. We need to move away from sewing together a whole range of disparate information systems and processes and doing the best that we can to designing by default an integrated service for health and social care that supports patients and properly engages those patients. So questions related to how to manage the risk and the scale of what we needed to do and how we were going to manage some of that technical infrastructure were natural. And we, at the end of the day, our colleagues in BSO, like the rest of health and social care, support the Encompass business case that was made.
So you're confident that that argument's won now?
I'm confident that we're well advanced in that argument. Will I think there'll be no arguments in the future? No, well, no, I don't think so. But at the point where we make that investment decision, then I think all of Northern Ireland is ready to weigh in behind it.
Part of the purpose of having a really good national strategy is that, as we were hearing this morning, you have a very large amount of data available to you so that you can make big decisions and do population health management and what have you. We heard some fairly elegant circumlocution from Will Smart this morning about how, on the one hand, you can tell patients that they own their data and they control it, and yet on the other, we're going to give it away unless you tell us you don't want us to. How do you square that circle?
And I think the conversation happens at different levels, really. So we've had that conversation in Northern Ireland already in regard to using information for direct care purposes. And I'll not get the definitions get quite tiresome, but I think the conversation has been had and resolved around using information for direct care or direct treatment purposes. In fact, in the various surveys and conversations we've had with members of the public, they're quite shocked when they heard that we don't naturally move the information we have from one setting to another. And the work that we've done on the electronic care record, and it did include, and not everyone recollects it, it did include leafleting every household in Northern Ireland to say, here's how we propose to proceed. If you're worried about that, please let us know, and we'll manage a process of ensuring we don't aggregate your information for this new electronic care record back in 2013. And I think we had some 50 to 60 people who said, I'm a bit concerned, don't do it for me, please. And I think about half of those reverted when they went to see their GP out of hours or whatever it happened to be and realised that that GP couldn't access their information because they had opted out. They had not realised that that was the effect of that decision. So the public, I think, have voted with their feet and said, for direct treatment purposes, we're not concerned. We understand the need for the information to be shared. There's a more subtle debate to be had, I think, when it comes to how we use information for secondary purposes. We know that the GDPR requirements will require us in due course to be clearer about how we use that information and to give opportunities for patient clients to consider whether they are content for information to be used in that way. There's some great lessons to be learned from our Nordic colleagues who have already created ways of showing to patients and clients what information is held and giving them some options, not carte blanche, but some options about whether that information should be shared. It's a debate that we need to have, and we haven't fully had it yet. We haven't been talking to the public, apart from surveys and small group work, about how we should be using information to improve the quality of our population health delivery for the future and better support research for the future. I think, if I'm honest, I think we were a little bit timid in the light of the care.data problems. We have been quietly making progress with our general practitioner colleagues, so we do have a risk stratification process in place here in Northern Ireland that's informed by data that comes out of all of those GP practices. GP practices have indicated that they're willing to see that information brought into a data lake within health and social care to better support that risk stratification. So we were hearing, I've forgotten Dave's surname, from Missouri yesterday about the work they had done to identify pre-diabetes patients and to stratify them so that they could intervene to prevent those patients from becoming diabetics in due course. And we have done similar work here in Northern Ireland. We have identified those patients through the work that we've been able to do with our GP colleagues. We don't yet have the investment happening to say, and now that we know who they are, what are we going to do to help? But there is huge potential to risk stratify working with our GP colleagues, and our GP colleagues are very keen to support that. That's an easy use case to describe to the public, and one I think that doesn't give any concern. It was interesting to hear Will this morning saying, and perhaps we should also be indicating to people that if they don't want their information shared, they may not get access to health and social care. I'm not sure how well that conversation.
Blunt,
yeah. It's the case, certainly the case for the primary use of data, but to be fair, health and social care patients have shown no lack of willingness or no real reserve about being happy to see that information being used for that purpose. I think the job is for us to demonstrate to them, here's what we want to use your information for. Here's why we think that has a benefit for you. And on every occasion that we have had that dialogue with patients, no one objects. But I think you have to say, well, what are you going to use it for? Not, can I have it and trust me?
I think we have to acknowledge that in the light of what's been going on with Facebook, it's a shifting scenario, isn't it? So to have a mechanism where you've got a ready consultation with, with your population is going to be very important to keep their trust. And I don't know what you've got in mind for that.
Yeah, well, so we do have some work happening now to create a patient portal, which is piggybacking off some of the work that we've done on the electronic care record. And effectively, it will be a learning ground for us as we move towards the more expansive use of information and engagements of patients in the context of an integrated care platform or the delivery of Encompass. But we launch in June this year a patient portal linked to the electronic care record and specifically aimed at dementia patients, which responds to an aspiration from Atlantic Philanthropies who worked with us to develop some of those proposals to better support those suffering from dementia as part of a broader thrust for that work. They've been very generous in their approach, and we've designed that portal in such a way that it could be used for any chronic disease grouping. Initially, it will focus on dementia, and we see that as a core avenue then for being able to open up to patients what information we hold for them and to create the opportunity to test what information they might be able to contribute to their record. And I think it needs a scalable mechanism such as that to begin to manage that process of ensuring that people are content and understand what it is, the information that we hold for them and how it's being used.
I gather that the whole HSE board is about to be dissolved, which might unfortunately include your role as well. The cynical might say that this is a way of delaying costly projects and kicking them into the long grass. Are you going to run into the long grass to catch it, or are you going to think of something different to do?
Well, first of all, the discussion on the future of the Health and Social Care Board is resolved. So there was a ministerial decision, I think it's now a little over 2 years ago, that the Health and Social Care Board would in due course close. So that element is not a surprise to any of us. I think we heard from Richard Pengelly yesterday the value that he places on the work that the board has done. And we've already had some indication about how that work would be provided for in the future. It's my understanding that colleagues in the department, from recent conversations with them, have resolved to create a new leadership structure in the department that will include the information role. I applaud that. I think that's the right thing to do. I think it's difficult to see how at the Northern Ireland level, with our relatively small population, with a department that has confirmed that it will lead and direct the service, and that's the language that is used, that they can do that without having a senior information owner sitting at the top of the office in the Department of Health. In light of that decision, I had already talked with colleagues in the department, and I had made a decision that if that was to be their direction, that I would exit the service, and I'll do that over the course of the next year. In the meantime, I'll continue to work with departmental colleagues to see that post or posts, or however they wish to express it, created so that there's clarity for the decisions that we need to make as we move on over the course of the next 3 to 4 years.
Right. About now, we normally turn to Twitter and see if you've got some questions from there, from those that are following. Have we got any coming our way? You'll have to speak up a bit, Dan, yeah.
Plenty, especially from Roy, who's doing his best to provide challenging questions.
Plus ça change.
Is the role of a CCIO on a board more than deputy?
I think the same as the role of a CIO on a board. And I suppose the point I was trying to make earlier is that not that we are wanting to have 2 people who lead that agenda, but that over time, the natural place for the leadership of that agenda is from care professionals who have an investment in information. I guess if we went back to, Roy will remember, to go back 30 years to the Griffiths area, when we were making serious efforts to find ways to involve clinicians in management, in general management, and I think the parallels are similar. I guess you could argue that it's disappointing that we've waited as long as then, but nonetheless, just as we have a need to invest in information leadership, whether it's clinical or non-clinical, ultimately I think all of us see that the service needs to be led and directed by care professionals. So whether we refer to them as CCIOs or whether in due course they're just CIOs, That's how I see that evolving over time. There may be a need to work alongside to support and enable. We know there are many pressures on our clinical community, but there's an appetite there, I think, and it's a core part of managing health and social care.
We do, just to observe that we do have one or two CIOs who are clinicians and who do sit on board, so it's very much moving to exactly as you described.
Another tweet from a registered also mentioning chief will there be a role for you mentioned CIOs, there are intent for a chief nurse?
Yes, there is, and we have a chief nurse, a chief nursing information officer in the audience with us here for Northern Ireland. Again, I think it is simply the case that where we are in that evolution is that the only place that has a full-time officer for information needs for nursing sits in the the Public Health Agency, technically the sister organisation of the Health and Social Care Board. I know that many of our nurse leaders are intent on creating the space and time for nurses to take on that leadership agenda, and we need to find ways to support them in that, just as we need to find ways to support doctors having those same conversations with allied health professionals. So that it's not narrowed down to one or fewer constituencies, and there's a need to build that information leadership, as for all areas right across the piece as part of our normal business.
If I go back to Roy, one other one, just drawing back on what you said before, there is always talk of need for a public debate. I think you spoke quite some length about that. The question really is, what is that forum? What does it look like? How do you show the evidence that you talked about, that you will look after that data?
Well, we did the usual formal consulting as part of developing an eHealth and care strategy, and it felt like a relatively stale process, it has to be said. So it is the case that I think we need a continuous process of dialogue with health and social care with those we serve, and we have more work to do to build those structures for patients and clients. Certainly there's an appetite when we looked at a range of developments. There are always appetites for people to come together in something that they have an interest in for the near term, rather than standing patient committees or whatever you would care to refer to it as. So there's an appetite from the public to be engaged. It needs to be more of a continuous dialogue. Certainly the work that was done by our colleagues in Scotland to launch what they refer to as the SPIRE process, similarly bringing together GP information to support better planning and health and care research for the future. It was really an intensive media campaign alongside working with individual patient groups. So I think it's more of a continuous dialogue rather than an edifice or a hierarchy of some kind.
Any more from Twitter? Different sources?
Well, I think when it comes to direct treatment, but maybe try and answer the question in reverse. So we have had recently established a regional information system for oncology and hematology, RESO, very good at our acronyms in health and social care, which has the potential to make a huge difference to the quality of care and the continuity of care that we're able to offer patients who are undergoing cancer treatment. Unfortunately, I think about 3 months ago, we had an outage in that system, and we had near panic. We were able to get the system back up and running really very quickly, but it brought home to those for whom a digital system was, an auxiliary alternative, was something you could use if you chose to, but if you didn't, there were alternative means of getting the information you needed to support patients. That increasingly we were becoming absolutely reliant on digital. And in a context where we become absolutely reliant on digital, if a patient presents and says, I don't want to share my information with you, how can you offer safe treatment? So for direct treatment purposes, I think that is a real debate. I think it's a different debate when we move off direct treatment.
So it was a fairly stark statement, wasn't it? You don't quite need data like you need blood, so it's not a really fair analogy, I don't think. Let's turn to the live audience, who've been very patient so far. Have you got any questions there? We'd love to hear from you and comment on what you've heard so far.
thrilled to bits.
Postprandial torpor has broken out clearly. Yeah. Nope.
Whilst they're getting the courage to come up with their thoughts, one more from Roy to keep things going. What will Northern Ireland IT-enabled healthcare look like in 5 years' time?
In 5 years' time, it would be my expectation that we would be in a position to have completed what we've described for both the acute and at least begun, if not completed, the work in a community health and social care setting. So I would expect that we will have a digital service offering in the acute sector, greatly supporting improved population health, and that we'll be able to, at least in 2 or more parts of Northern Ireland, demonstrate an entirely integrated system for community health and social care, perhaps for those 2 organisations that we're currently working with that are working on make, do and mend community information systems, particularly in South Eastern Trust and in the Northern Trust area, and that we will have demonstrated the benefits that brings, and we'll be in the process of moving that out across the rest of Northern Ireland. 5 years is a relatively short time frame, and it can be very tedious and frustrating, but we can cast our minds back and look how long it took us to get where we are for some of those key systems. So in some of our trusts, they have been implementing community health and information systems now for 7 to 8 years. And yet when we look ahead and say this will take 5 years, there's a sense of frustration of why so long, what's going to take that time. But proper planning and preparation and delivery for it will take that long. But certainly we would expect to have implemented in the acute setting and to have commenced the process of implementing in a community health and social care setting.
So let's try again in the audience. Does that prompt any questions in your minds? Apparently not. Sean, thank you so much for being so frank and open. Many congratulations for having got a very difficult project as far as you have. You've clearly got very good clinical engagement because we've seen it and heard it. So when it succeeds, then it's going to be in great measure because of all the effort that you've put into it and all the hard work. So many, many thanks for putting up with the questions, and thank you for being such a good sport. Shane.
Thank you, Michael.
Sorry, just a final question really, Sean. Is there anything you'd like to say to this platform, this audience, you haven't had a chance to talk about this afternoon?
I think we've given most of the issues a fairly thorough airing, Shane, in the course of the afternoon. I mentioned that I personally will make my exit from the service over the course of the next year. I have every confidence in the folk who are in a leadership position within health and social care leading information. We have Gary Loughlin in the room here as a program director for Encompass, and Gary's been doing a fantastic job for Encompass, well supported by a broad clinical community, many of whom again are in the room today. I would hope and expect that prior to my departure from the service, and as we talk with our colleagues in the department, we'll clear away some of the necessary re-architecting work that we need to do in terms of how the information agenda is to be led next year and the year beyond. And maybe just to say now in this setting, I'm here for some time to come, but to wish the best to those programs on which health will depend so heavily for a sustainable offering in the future.
Final comment from Roy. Thank you very much to both of you. Exceptionally well. And I think that's a 9 out of 10 from him.
Down with faint praise again. Thank you very much, Sean.
Thank you.